everyone, this is Sanchika. I welcome everyone for the Cypher Echo webinar on good and replicable and innovative practices of tobacco control in India. This is the fifth webinar in the series. And today the topic is advancing operational research in tobacco control since COTPA 2003. It is by our speaker. Our guest speaker is Dr. Mangesh Pednekar, who's a director in Healis Mumbai Institute for Public Health. Also, we have today Dr. Saurabh, Vashney, the CEO and executive director of a very reputed institute in India, that is the AIIMS Deoghar. Very warm welcome to you, sir.
Thank you.
Now I will request Mr. Arun Verma, sir, who is the Director of Finance and Operations, for the welcome address.
Next slide, please. Good afternoon, everybody. I am Arun Verma. I am from the team Cypher. I am really delighted to welcome our chief guest of today's this webinar, Professor Saurabh Vashney, who is an Executive Director and CEO, All India Institute of Medical Sciences, Deoghar. Professor Sonu Goel could not join today's, and I welcome Dr. Mangesh S. Pednekar, who is our resource person for today, who is a director in the Healis, as well as he is a founder member of this Healis, who will be now making a very presentation on advancing operational research in tobacco control since 2003, since COTPA 2003. I also welcome Director Mr. Rakesh Gupta, who is the Director of the Cypher and who is a former Director Public Health, Director Health Services of Punjab Government. I also welcome Dr. Sanchika Gupta, Manager Projects from the ECHO. I also welcome our eminent participants as well as public health students who are part of this webinar, who have joined recently on this seminar. As you know, Strategic Institute of Public Health Education and Research was established in 2018 with the fundamental purpose of creating a specialized public health workforce that can plan, execute, and monitor national health programs and public health initiatives for tackling emerging public health challenges. We are working on all public health issues with a special focus on non-communicable diseases. In the last 4.5 years, we have organized more than 90 physical as well as virtual workshops and consultations. Resource Center for Tobacco Control, a joint initiative of PGI, MER, Chandigarh, and the Union, is emerging as one of the most sought-after platforms that showcases tobacco control initiatives, updates, policies, resource materials, etc. from the length and breadth of the country. It has helped in strengthening national control tobacco program to a great extent. Once again, I welcome everyone to this webinar. Now over to Dr. Sanchika.
Thank you, sir. Now I will request Dr. Rakesh Gupta, sir, President of the Cypher, for discussing on the objectives of the webinar.
So thank you, Dr. Sanchika. Since Dr. Sonu Goel is busy somewhere else, so I'll be letting you know about the objective of the webinar. The Resource Center for Tobacco Control under the Department of Community Medicine and School of Public Health, Chandigarh, PGI Chandigarh, organized a national conclave on best practices under National Tobacco Control Program in India. The aim was to compile various initiatives undertaken by the states and document it at a national and sub-national level with respect to manpower, empower, and NTCP for effective tobacco nicotine control. So 25 best practices in tobacco nicotine control were compiled from various states of the country. They have been identified as the best practices in terms of its outcome to strengthen the tobacco control in the specific region or community. Cypher was a collaborator in this event, and these case studies, they cover almost each and every part of the tobacco control, from advancing leadership and management in tobacco control in India to changing the taxation policy on tobacco products in the country. The presentations by experts will help in increasing the awareness and facilitate cross-learning among the stakeholders for strengthening the NTCP in the country and sensitize the stakeholders on best practices for its replication in the other states. So today's our chief guest is Professor Saurabh Vashney. As told you earlier, he is Executive Director and CEO, All India Institute of Medical Sciences, Deoghar. And we have with us Dr. Mangesh as Pednekar. He's Director of the Healis Mumbai, and he'll be talking about advancing operational research in tobacco control since 2003. So thank you. Thank you, Dr. Sanjay.
Thank you, sir. Now I would request Dr. Rakesh to introduce our chief guest, sir, Professor Dr. Saurabh Vashney.
So we are actually honored to have Professor Dr. Saurabh Vashney with us. As I told you, he's the Executive Director and CEO of the AIIMS Deoghar. He's a national member, IMA Standing Committee for National Initiative for Safe Sound, and national member, IMA Standing Committee on Cancer and Tobacco Control, member Standing Committee Building and Auditorium, NISS. He's also member WHO SEAR Group on Deafness. He's member of the Sound Hearing International Group. He's member of the Specialist Board, ENT, since he's an ENT specialist. National Consultant, FOPL. Then he's also member Healthcare Sector Skill, member Institute of Senate and Institute Senate of IIT, Dhanbad. He is a State Nodal Officer, Uttarakhand State NPPCD. So till 2013, he was the State Nodal Officer. Then Indian Contact International Agency on Tobacco and Health. So this was in 2000 to 2008. And he has been awarded various scholarships and various awards have been given to him. So we are really honored, sir, to have you with us. I met him recently in a meeting, in a consultation on BDs, actually, in Delhi. It was organized by AIIMS Jodhpur. So we welcome you, sir. Thank you.
Thanks.
So, Dr. Saurabh, I will request you to please talk about this webinar.
So thank you very much for those kind words, Dr. Rakesh. It's my proud privilege that I am a part of today's webinar, and I've been given an opportunity to interact and learn from people who have been really working so well in the field of tobacco control in the country. My regards to Dr. Gupta, Dr. Goel, who could not join, is a close friend, Mr. Arun Verma, Dr. Sinchika, and my regards to Dr. Mangesh Pednekar, who is the director of Healis. I think the topic which has been decided for the webinar is a very, very appropriate, that advancing operational research in tobacco control since COTPA 2003. We know that operational research is one field where our country needs more focus and emphasis. I know that being a partner to the union has already established Operational Research Center, Center of Operational Research, which has done excellent work in the field of tuberculosis, HIV, and other non-communicable diseases. And now they are supporting for the tobacco control also in a big way. So I think it's a very appropriate topic, because in many, if we talk about operational research, many even low-income group countries have done better operational research work than compared to our country. So we have to do introspection, deep thinking about advancing the field of operational research in tobacco control, because many things which we know can be replicated, duplicated, and we can achieve more by using operational research methodology. So I feel privileged to be a part of this, and thank you for inviting me. And really, it's an honor to listen to such wonderful presentation. Thank you very much. Thank you.
Thank you, sir. Thanks a lot.
Now moving forward, I would like to introduce you. Our guest speaker for today is Dr. Mangesh S. Pednekar, who is a director of Healis in Mumbai. Dr. Mangesh is one of the founding core team members of the organization. He's also a visiting scientist at the Harvard T. Chan School of Public Health in USA. His academic accomplishments include a doctorate in epidemiology from the School of Public Health, University of Tampere, Finland, and a master's in statistics from Mumbai University. Dr. Mangesh is actively leading in many national and international epidemiological research studies. He has already published more than 100 scientific research articles in high impact factor national and international journals, and has also contributed as an author in some books and scientific reports. He also serves on editorial board of few scientific journals and has served as a reviewer for many national and international scientific journals. A very warm welcome to you, sir. Over to you, sir.
Thank you very much. So thank you very much for providing me this opportunity. So I really thank organizers and our chief guest, Dr. Saurabh. It is very nice to get interaction, like know you and meeting you first time on this webinar. So very much looking forward to like interact you in future as well. So I must say that the brief introductory talk provided by chief guest basically has set the platform for what are the basically requirement of operation research in relation to tobacco control. So I am very, very delighted to share, as Dr. Saurabh was mentioning about, like even some of the lower income countries are also doing better operation research in the context of like, but I am very delighted to share in case of the tobacco control, I must say the kind of experience and specifically methodology I'll be sharing in this presentation, which is basically of a very high international standard, because this study is based on a multi-center like global project, which having a standard methodology and standard tool adopted across many countries in the world. And this is the kind of a first study initiative which is taken with major focus primarily on policy and policy implementation, because a lot of research is done in relation to harmful effects of like risk factors and other, but policy focus thinking in the terms of the prospective cohort approach. So this is the kind of a first study which is going on like across more than 30-40 countries for almost more than 2 decades. And that has contributed very significantly in terms of the improving the policies, also monitoring the policy, and significantly contributing the tobacco control efforts, not just in India, in the across the world. So can we go to the next slide, please? So overall, I will try to cover like the next 30 to 35 minutes. So main objectives. Then I will be briefly talking about the TCP India survey. Then I will be more talking about the sampling plan for each state, as this is a multi-state kind of project. And then we will be also introducing a concept called replenishment plan. So how we can replenish the loss to follow members, so that we're also able to maintain a uniform standard kind of sample, which can provide a significant findings throughout the longer period of time. So can we go to the next slide, please? Okay, just to state you, like some of you might have heard who are working in the tobacco control, that International Tobacco Control Project is basically a multi-country prospective cohort study designed primarily to measure psychological and behavioral impact of key policies of WHO FCTC. So that is the reason I say that the focus of this research is primarily based on policy and policy related research. So this ITC survey is being conducted in more than 30 countries for almost more than 2 decades. And some of the countries basically are doing the surveys annually, so they can track the progress of the tobacco control policy related research annually, as compared to like some of the bigger countries and low resource countries. So it has been like 3 years, 5 years, or subsequently, depending upon the funding available. So talking about this ITC project global, so it is called TCP project in India. For obvious reason, we are not calling this as a ITC project in India, because most of you might be knowing that we have an Indian tobacco company, which is also abbreviated as ITC. So that's the reason the starting point, we changed the tobacco ITC project name in India to Tobacco Control Policy TCP project, and is again a kind of a prospective cohort study. So interestingly, how like even a smaller sample, if it is selected in a systematic way and maintained in a systematic way, can result in a kind of a representative study finding over the period of longer period of time. Can we go to the next slide, please? So I think, see, most of the participants on this kind of webinar like are well aware of the tobacco control policies in India. So I will not spend a lot of time on stating about which policy is introduced when and why. But I would like to highlight the important point, the timing of the TCP survey. So if you look at the timing of the TCP survey, the pilot study was conducted around 2007. Then the recruitment of the cohort was done in between 2010 and 11, where we have recruited around 8,000 tobacco users and around 2,500 non-tobacco users. And these cohort, basically, we have followed subsequently. The first follow-up was done between 2012 and 13, and the second follow-up was done between 2018 and 19. So if you look at the year, so these are the years, basically the major tobacco control policies in India was introduced, or basically major changes were implemented. So that is the reason this survey provides a significant platform in terms of the tracking, how the existing policies are progressing, and at the same time, any changes or any major changes happen during the subsequent year, how they are impacting to tobacco users as well as to the non. So can we go to the next slide, please? Okay, so the primary objective of this TCP project can be broadly categorized into three main objectives, where we are trying to study the effectiveness study aims, mediation and moderation study aim, and contextual study aim. So each study aim we can discuss subsequently. So we can, next slide, please. So if you can see clearly, the effectiveness study aim primarily we are trying to study is to examine whether a policy introduced in India will affect the self-reported tobacco use behavior. So first we are trying to see any policy, how it is impacting to the individual tobacco user. Then we are also trying to study how it will impact levels of general psychological variable that have been identified in the past research to be associated with tobacco use and quitting about tobacco. So there are a lot of research has been done in relation to tobacco dynamics, tobacco use, tobacco quitting, facilitators, barriers. So we are also trying to study from this study as how the policies are also impacted in this psychological variable. In addition, we are also trying to examine whether a policy introduced in India will enhance policy relevant psychological variables among tobacco users. So again, more focus. So how the existing policies or new policies are affecting psychologically among the tobacco users will be also one of the primary objective of effectiveness study. Maybe you can go to the next slide. So when we talk about mediation and moderation, so what we are trying to study is to examine whether the effect of FCTC policies that have been introduced in India are being offset by compensatory behavior. So these are the important factors. So how it is getting affected on the FCTC policy. Then we also examine whether the effect of tobacco control policy are moderated by factors such as demographic variable. When we talk urban, rural, between countries, low middle income countries versus high middle income countries. So those kind of, then personality variable, environmental context, and tobacco use history of the individual. So whether history of tobacco also plays any kind of role in that, that will be also studied. Third, mediation and moderator objective is basically to whether the effect of each policy on tobacco use behavior are mediated by those psychological variables that have been identified by past research. So again, we are trying to see that whatever the established facts available in relation to tobacco using or tobacco quitting, so whether it will get any kind of moderation in relation to tobacco policy implementation. Next, please. And the contextual study aims, which includes, as you can say, that we are understanding the natural history of tobacco use and cessation, because since this is a prospective cohort study, so at baseline, we are also recruiting users. So they, in the next 10 to 15 years, I think users, some may become past users, some non-users become users. So those kind of history will be studied, and what are the dynamics and how the policies are playing a role in this change over time will be studied. And as an advantage, this is the global study. So we'll be comparing this between other countries, ICC countries. So total 29 to 30 countries are there. So those results can be also compared. So as Dr. Saurabh was mentioning, so within developing countries also, how the policies and its association with using and quitting in Bangladesh versus like other developing countries, whether they have similarities or dissimilarities, especially when types of tobacco use are similar. Smokeless tobacco and BD smoking is very common in India and Bangladesh. So those kind of also comparable studies can be possible as a part of this study. Additionally, we compare the impact of FCTC policy, as I said, LMICs versus high income countries. So this is the first time, because when we initially, the international collaborator approached us, so the global study was primary focus only was cigarette smoking. So when we started doing our pilot study, so that is the stage where we started thinking in terms of, okay, in India, cigarette smoking is important, but in addition to cigarette smoking, BD smoking and smokeless forms of tobacco are equally important. So what are the ways these tools can be adapted or modified to the requirement of the developing countries or country like India? So that has resulted into, like, for example, initially the cigarette smoking survey was, let's say, 30 to 45 minutes. But when we introduced our smokeless tobacco and BD smoking, so the mixed user survey, at times it was around 2 hours. So that was a longer duration survey, and that is a kind of a very unique information which is available in terms of the different types of tobacco in this study and their policy implications. Next slide, please. Okay, so talking about where this TCP India study was conducted or carried out. So in India, it was conducted in 4 states of India: Maharashtra, Madhya Pradesh, Bihar, and West Bengal. Next slide, please. So what was the sampling frame? I think we have just like have a representation of urban and rural. So what primarily we focus is major cities from these 4 states like Mumbai, Indore, Patna, and Kolkata were selected. And from these major cities, I think 10 wards were selected. And from each ward, 4 enumeration blocks were randomly selected. So in urban area, the sampling frame was for each ward, around 150 households were randomly selected. And how the rural area was selected? So rural area was again selected keeping the main city as a base or major city as a base. And within 50-kilometer radius, rural areas were like from those areas, the villages were selected. So 4 villages were selected, and from each village, around 125 households were enumerated. So in each state, around 1,500 urban households and 1,500 households from the rural were enumerated for each state. And from these 2,000 enumerated households, 2,000 tobacco users and 600 non-tobacco users were recruited. So in summary, from each state, around 2,600 respondents were recruited from each state. So 2,600 multiplied by 400. So that is the number of around 8,000 users, and 2,500 non-tobacco users were recruited in this part of the study. Next slide, please. Okay, so the most interesting part, because most of the time when the longer and prospective cohort studies are done and there is a requirement of a global comparison, so we have to have a unique and standard tracking system. So as a part of this, the enumeration form were recruited because there was a systematic methodology was used, how the household gets selected, and after the household selected, how the individuals within the household get selected. And that was the reason this study is basically unique and representative as compared to other studies. So you can see from this form, the unique ID, household ID was provided. And then there were unique individual ID, interviewer ID was also provided. Any household related information was collected from either the head of the household or the key informant, which is identified available at the time of the interview or the visit, who can have a reasonable information about each member of the household. So you can see that there is a key informant. So that key informant name is very, very crucial, because then subsequent information is subject to the key information. Can we go to the next slide, please? So it's just that we have maintained the record of the household which is successfully enumerated. Additionally, similarly, we have also maintained the record of the household which is refused, because non-response is also equally important to find out and to understand whether there is any kind of bias or some kind of like how the representativeness of the results are there. So we have maintained the refusal. So in the refusal household, what we are trying to collect is basically number of adult members in the refused household and how many of them are using tobacco, so that we can get the prevalence of tobacco use in the refused household as well. And then we also maintain the record for the refusal. Next slide, please. Okay, so this is very, very important, and this is about the enumerated household. So from the enumerated household, with the help of the key informant, we have identified the status, tobacco use status of the each individual. And how it was done? It was done using asking 2 questions. Question A and B. So question A is basically, do you currently smoke at least once a month? So if somebody says yes, so he will be basically a current smoker. And question B is, do you currently use smokeless tobacco at least once a month? If somebody says yes, so he'll be current smokeless tobacco use. And if anybody says yes to both A and B, So they will be categorized as a mixed user, those who use smoking as well as smokeless. And anybody who says no to both A and B will be recorded as a non-user. Next slide, please. So with these questions and criteria, so as you can see that the first person listed on this form B1 in the household information form is the key informant. So first we identified the key informant, then we have collected the demographic information of gender, age, his individual tobacco use status, and similarly the family members tobacco use status. And additionally, we have also recorded the relationship to the informant. So all other household members who are enumerated from this household, so their relationship to the key informant interview was also maintained. And you can see that each individual's gender, age, and their tobacco use status were recorded. Next slide, please. Okay, see this form B2, actually here we are trying to record gender-wise tobacco users in the household, because we are also, this study, we are also trying to estimate the prevalence of tobacco use in the selected sample. So you can see that we have recorded for each household, adult male tobacco users, adult female tobacco users, adult male non-tobacco users, adult male female non-tobacco users. And for example, there is the possibility that some of the household members, the key informant may not be aware about their tobacco use status, especially for the younger people. The parents may or may not know that whether their children or adolescents are using. So unknown status were also recorded, because this is as recorded by the key informant. So this information was recorded. Additionally, we also have recorded number of children aged 0 to 5, 6 to 12, and 13 to 14. So this information was also recorded. And finally, any household key informant we provide all this information. So they were given a code of 12 that this household is successfully enumerated. Next slide, please. Okay, so after the household is successfully enumerated, then it starts with the individual level. So from the household member, we have to select, we have to approach the users and non-users to complete the required survey. So then again, we are maintaining, because it is not possible that each survey will take place on the first visit itself. So that is the reason in this survey, we are systematically recording individual status until the interview is completed. For example, what you see in the screen, this individual ID number 3, 15 July, he was approached first time. So on his first visit, he informed that he is too busy. So he asked the interviewer to come back on 18 July. So our interviewer went back on 18 July. And then on that day, he has completed that survey. So code 7, in the above, you can see that code 7 is basically the interview is completed. So this information was recorded for each individual. Next slide, please. Again, as you know, this is a prospective cohort study. So, and this will be longer term follow-up. So we required complete address again to go back to that individual household. So household address and phone number and PIN code was properly recorded. In addition to that, we also recorded alternative contact person who is basically not living in the same household, who can be close relative, close friend, who will be knowing about the status of that individual in his absence. So that is the reason that alternative contact number was created, his address, his telephone number, and his relationship to the informant was also maintained. So just to find out how reliable that person will be knowing about the family. So this information was found to be very useful in the follow-up times. Next slide, please. Okay, so now since we have listed n number of people in the household, so how the tobacco users will be selected from each household and how the non-users will be selected from each household. So from any given household, so maximum 4 family members who are 15 years and above, who are tobacco users of any kind, can be eligible to participate in this survey. If any household has only 4 or fewer number of tobacco users, say everybody will be interviewed. For example, in any household, there are 3 tobacco users, so all the 3 members will be interviewed as a tobacco user. But if there are more than 4 tobacco users in any household, then the priority will be given to all females. So all female members of that household will be interviewed first. So if it up to 4, so maximum, if in any household there are 4 females are there, all 4 females will be interviewed, and then person will go to the next household. So if there are lower than, let's say 2 females are there, so only 2 females will be interviewed first. And then from the male members, they will be selected for to cover up the maximum 4 number in that household. Next slide, please. See, just for example, in this household, you can see that the total 8 family members are there. Out of these 8 family members, there are 4 females, 2 are user and 2 are non-user. So I am talking about how the users are enumerated. So as I said that the female will get the weightage in terms of the user female. So these 2 female will be interviewed first, and from the remaining male tobacco users, they will be given a number 1, 2, 3, because we require to interview 2 more male from this family, and there are 3 male. So how the 2 males will be selected from these 3 members? So we will be using a die. So we will throw a die, and whichever number comes, so that number 1, 2, or 3, so that 2 people will be recruited. So from this family or this household, 2 females and 2 more males will be enumerated. Next slide, please. So as I explained that if it happens that in any of the family member all are female or most of them are female, so if there are more than 4 females, again all female users will be given the number 1 to 6 and a die will be thrown and 4 females will be selected from this household. Next slide, please. So how the non-user will be selected? So as you may recall, we are saying that the total 2,600 households, basically we are 2,000 households. So every third household will be enumerating the non-tobacco users. So every out of the total 2,000 households, so every third household non-users will be recruited. So around 6,000 non-users will be enumerated per state. Next slide, please. So again, what if there are more non-users in the household? So again the same methodology, but here male female will be given equal weightage. So if there are 4 adult male or female are non-user, so numbers will be given irrespective of their gender, 1, 2, 3, 4, and the die will be thrown, and the number which gets selected, that person will be recruited in this study. Next, please. So in general, this household survey basically will be information will be provided by the head of the household and the key informant. And the individual survey, there are 7 different types of survey were administered. So there will be only cigarette smoker, so C survey will be administered. Only BD smoker, B survey will be administered. Dual smoker, if somebody is cigarette as well as BD smoker, so the dual smoker survey will be administered. If somebody is exclusive smokeless tobacco user, then L survey will be administered. And if somebody is mixed user, so we name them as the M survey. Anybody who is a smoker as well as smokeless tobacco user, so M survey will be administered. And if somebody is non-tobacco user, then he will be never tobacco user at baseline, or he is a basically past user at baseline. So those will be used as a non-tobacco user survey. And in follow-ups, the people who reported themselves as user as baseline, the quitter survey will be administered. So these are the different types of surveys. So non-user survey like can range around 30 to 35 minutes, whereas mixed user survey it took around like 2 hours to complete that survey. So that was the range of the time required to complete all this kind of survey. Next, please. Okay, so why the screeners are required? So screeners were used to verify the respondent current tobacco use status at each follow, because the person who reported themselves as a smoker in baseline, he may change to become a past user, or he may become a smokeless tobacco user, or he may become mixed user. So every follow-up time, we have administered a screener to identify their current tobacco use status. One more reason the screener was used, because as you know that in each long-term follow-up cohort study, there is a loss to follow. So in this study, so any loss to follow was replenished by equal number of numbers in the subsequent follow-up. So this is the kind of, so at any given time, the cohort size remains same across the 15 to 20 years. Next slide, please. So just to explain you how the replenishment was done, like for example, at any given, so first weightage was given that we will be able to ensure that the non-response remains similar at the ward or the village level, because as you remember, the sampling unit was selected 10 wards per city and 4 villages per rural area. So that is the reason we ensure that at each ward level and each village level, the non-response remains. For example, 10 people were lost to follow up in any specific ward. So we ensure that from that ward, 10 people will be replenished. So how they will be replenished? So they can be replenished from the same household if there are any other users available, or they can be replenished from the same enumeration block or village, or they can be replenished from the new enumeration block or new ward. So this is how the replenishment, and we prefer to replenish younger cohort members. Like for example, you can see that I have mentioned that 15 to 20 and 15 to 80. If any member is lost to follow from baseline survey or wave 1, so the new cohort member replenished was in the age between 15 to 20. And if anybody who is recruited in the first follow-up or wave 2, they will be replenished between the age 15 to 18 to take care of the age difference between, years between two surveys. Next slide, please. Okay, so in summary, so this is why this study was unique and representative, because we followed a systematic approach, and this approach was followed across all ITC countries of this project. So then we initially at baseline we contacted, and for follow-up we have recontacted the household. Then we identified the key informant or head of the household, and the head of the household survey was administered. And then after the head of the household survey enumeration is done, then we randomly select the users and non-users from the household and then get the consent from them, administer cleaner or survey, and check the survey for completeness and move to the next household. So there is a special case available that substitute was allowed only in the case of adult non-user of tobacco in the same household if there was a specific reason that he is for health reason or not available for longer period of time, or due to some kind of language barrier, if he is not able to continue in the study, only then the non-users can be replaced from the same house as a special case in this study. Next slide, please. Okay, these are some of the pictures of our field investigator and the survey in actual their home. So these are pictures from Madhya Pradesh, Bihar, West Bengal, and Maharashtra. These are some of our interview, and the small token of appreciation was given to them as a part of their time to the survey. Next slide, please. So the most interesting part, I'm not talking a lot about like study finding, but I'm here primarily focusing about loss to follow-up and how systematically this loss to follow-up can address by replenishing the cohort member. So if you can see that this slide is talking about user versus non-user. As you know, that we have to be very mindful about whether in loss to follow-up introduce any kind of bias. So if you look at these results, overall, you can see that around 11% to 10 to 11% non-users as well as users were lost to follow at the first follow. Whereas in the second follow, that is wave 3, you can see that around 30% user and 30% non-users, they were lost. So that's the reason. So the loss to follow in the context of users and non-users, they were similar. So there is no specific like only users were leaving the study or only non-users were left. Those kind of problems were not there in this study with this systematic approach. The next slide is about whether any loss to follow differences was there between male and female. Yes, to some extent, as we always know that male is the working population. So most of the time, the non-response was slightly higher in male than in female in wave 2 as well as wave 3. But you can see that throughout the study period, we are able to maintain around 6,300 male and around 4,200 female across next 10 years of time. So with this replenishment strategy was able to be useful in terms of maintaining the cohort size same throughout the period. Next slide, please. So urban rural strategy. This is another there is a as we know that urban people are more time constraint are there, a lot of busy lives are there, and especially when we are talking about major city. So it is estimated that urban non-response will be higher than the rural non-response, and it is quite visible in this study also across all the 4 states and between waves also. And as you can see, but this replenishment strategy is able to help us maintain around 7,700 participants in urban area and 2,800 participants in rural area. And the loss to follow was slightly higher, that around 12% in urban area versus 8% in rural area. But this replenishment strategy help us to maintain the cohort size similar across the 10-year period. Next slide, please. So basically, on this note, I would like to acknowledge our as Healis member, also my co-investigator and study team member, and our international collaborator for this study is University of Waterloo, Canada, and they are the one who is also running the project across all the 29 different countries as well. So next slide, please. So in summary, what I'm trying to say is basically if your study methodology and your like protocol are standardized and basically can be maintained and executed in a systematic way, even with a smaller sample, we should be able to have a effective kind of findings which will help us to monitor existing tobacco control efforts and policy effort, not only within the country, but the standardized methodology used across different countries are also able to provide you comparable data versus like India versus Bangladesh, low middle income countries versus high middle income countries. And it is the standard policies which is formulated by WHO FCTC. So those are the same measures are basically used and followed across the survey across the country. So this is the reason even this systematic way of approach is going to help. And you can see that the global adult tobacco survey is another example of similar kind of standardization done across the country, and that is also providing a systematic comparable data available in the country. So on this note, next slide, please. I would like to thank you for your participation. I am happy to take any questions.
Thank you so much, sir, for your excellent presentation.
Thank you.
So just to briefly summarize what I understood from the presentation, sir has really gave for this Sir has focused specifically on the methodology of and maintaining the standards of methodology with the international research standards so that we are comparable and our Indian research studies are highly quoted within the international forum as well. So the survey was done across the years in the 4 Indian states, and it was highly focused on the research methodology and also focused on the smoking users, including cigarettes, BD, dual smokers, and also focusing on the users of smokeless tobacco, and also non-users and quitters. The main part, or I would say the heart of the survey was on the how they will follow up to the lost users, how they will come up with all those users which are going to be lost. So that was also extensively replenishment strategies was based on, and specifically focusing on the younger cohort so that they can be followed up in the later stages as well. Thank you, sir, for the excellent presentation. Now I will hand over to Dr. Rakesh, sir.
So thank you, Dr. Sanchika, for very nicely summarizing the whole presentation. So I'm really thankful to Dr. Mangesh. Actually, I was expecting just 30, 40 participants in this webinar because this was of interest for people who are into operational research, mainly the academicians. But I'm really surprised that more than 90 people they have joined this webinar. And I hope, because I'll have to see the recording again to comprehend what has been actually said. So being a clinician and into public health for some time, but it is really difficult to comprehend for people like us. But those academicians or the public health students, they'll be able to comprehend it better. So thank you, Dr. Mangesh. Dr. Sanchika, can you take a snapshot of everyone? I'll request all to please switch on their videos so that we can take a snapshot. Yeah, Dr. Sanchika, please take a snapshot.
Yes, sir. I'm taking. Give me a minute. It's done, sir.
So I could see Dr. P.C. Gupta, Dr. Rakesh Gupta from Rajasthan Cancer Foundation, Dr. Shipra Deshpande, Dr. Aruna, Dr. Dilip Acharya, Mr. Desh, Ms. Sharing Bhutia, Gurpreet from GSA, Dr. Ramprasad, Ms. Susan, and there must be many which I'm actually, the names I'm missing because I couldn't see all. I'm really thankful to all of you who have joined. And I'll just request Dr. P.C. Gupta, because he was part of this study. In fact, he initiated the study. So I'll just request him to just let us know just give his comments first.
Thank you very much, Rakesh, for asking me to sort of comment on this. I think Dr. Pednekar has presented extremely well in minute details the methodology, survey methodology of this study. And as he said, Jeff Fong had started this ITC, what he called ITC, in International Tobacco Control Policy Project in several countries with uniform methodology. You know, when he came to me and we agreed to do it in India, it became a much larger study than it is there in other countries, simply because, as Dr. Pednekar explained, everybody else had one questionnaire on cigarette, and we had to develop and administer 5 different questionnaires, you know, on BDs, cigarettes, smokeless tobacco, and mixed use. So we had to have different questionnaire for every group, and some of them, as he said, became very long also. But the survey was administered, has been repeated 3 times. And if you see the questionnaires, you know, it's a huge wealth of information. And we have analyzed quite a bit of it. In fact, for the first TCP wave 1, a very detailed report was made, and it's available on our Healis website and also on Waterloo website. Then for second wave also, there is a report that is available. For third wave, there is a technical report, and almost continuously research papers are being written using this data on the effect of all the measures that are there in India on the tobacco control policy. And in fact, we invite researchers everywhere in this audience and as well as anywhere to look at our data set, look at our report, look at our questionnaire, and think whether they would like to use the data to address a question of a policy question of their interest. And if they think that they can do it using the data and would like to use our data, they can simply write to us. It has to go through a protocol since it's a joint collaborative project. The proposal has to go through a protocol, and if it is accepted, the relevant data set are made available to the researchers, and they can write and publish. Of course, that is always in collaboration. Several papers have been already published in this way, and more are under publication. So I encourage everybody to really use this huge data set for answering specific questions that they have in mind, or exploring ideas further on tobacco control policy, effect of the intervention measures and policy measures on actual use of effect on the use of tobacco and other parameters. So thank you very much. Thank you all very much for your attention, and thank you, Rakesh, for giving me this opportunity.
Thank you, sir. Thanks a lot.
In fact, just to add to Dr. Gupta's point, I think there are already few people have done their PhD using TCP India data, and this data has been used for master thesis, not just Indian student, but international student. So as Dr. Gupta said, we are very much welcoming if any PhD student or any researcher wanted to use data and like publish and use for dissertation, we'll be very happy to collaborate.
Thanks for the offer. So, Dr. Saurabh, can you please briefly comment upon the presentation?
Yeah. Dr. Gupta, I think it was a wonderful presentation of an excellent work done in our country. And it was very well drafted protocol and follow-up, as mentioned by Dr. Mangesh, presented, and Dr. Gupta has already mentioned that so much has been extracted from this work, excellent work done by this group. And further, there is a hope that we can use this information for further publications. So I think that is itself speaks about the wonderful work that has been done. What I only want to point out is that I think as we started the interaction with that operational research in our country needs more focus and emphasis. And I think such kind of work is definitely will be a guiding force to think about among the researchers to take up operational research in a more outcome-based mode. And what we need to focus more also on in our country is on the longitudinal research, because what we have been doing research, but I think it was a wonderful cohort study they mentioned, and that longitudinal research is also a need, because when we talk about because we know as a scientist that every research is based on the two criteria, cause effect, effect cause, is vice versa like that. So a longitudinal research is also need of the country, and it's the need of the world also, but need of the country means I talk about our country. So thank you and congratulations for sharing such a wonderful work. And I think many researchers will be encouraged to do something like this, at least take their help in whatever the data they have collected. So that can also be converted into research outcomes and publications. Thank you very much. Thank you.
Thanks a lot. Thank you. So if anybody has any question or if there's any comment, I can see Dr. So anybody can just unmute yourself and just ask questions, please. Or if you have any comment to make. So I can see Dr. Sahana. So she has a question, why more women were considered in the household? You said 4 or less number in the household. So can you comment, sir, Dr. Mangesh?
Yeah, I think, see, as you know, basically the weightage was given to women is basically to have a proportionate balance, because most of the time in most of the surveys, the like male get recruited more as compared to female. And at the same time, we also wanted to get a representative sample of women in this study. And that is the reason we have given more weightage, especially in the context of user only. So more, and especially like when you talk about like rural areas and the prevalence of, like, we are here trying to study the different types of tobacco use. So women, smokeless tobacco use prevalence is comparable, and then but at the same time smoking women is also low. And if you compare the prevalence of tobacco use among male versus female, so male has higher prevalence than female. So that's the reason we know that to get a reasonable number of like female tobacco users, so we have to give a slightly higher weightage to female tobacco users as compared to male tobacco users.
So there's another question from Dr. Aruna. She says that role of extraneous factors influencing tobacco use behavior during follow-up. So this is the question.
What is the question?
The role of extraneous factors influencing tobacco use behavior during follow-up. Or Dr. Aruna, you can just put the question yourself. Just unmute and just put your question.
Yes, sir. Like during the follow-up surveys, like was there any role of this tobacco control policies on the tobacco use behavior among the recruited population, the cohort?
Yeah, obviously, I think, see, it was quite visible in terms of, see, again, one of the interesting observations when I mentioned at the beginning of the presentation, the timing of TCP survey were important, because, for example, the survey like administered around a major policy which is implemented. So
Yeah.
in a period of 6 to 9 months or 6 to 1 year. So the impact of that policy was quite visible in terms of the questions in relation to tobacco policy were responded versus the same question asked over the period of time. Let's say that COTPA implementation was done somewhere in 2003. So in the survey of 2007, the kind of responses versus 2008, 17, 18. So that is like, for example, again, you can think about smoking causes lung cancer. The harmful effects of tobacco knowledge is basically now reaching at the saturation point where more than 90% of the population, they are already aware that smoking causes. So that is no more providing any kind of like more information in terms of their decision making. Whereas now it is high time for us to think about whether we can provide, in addition to harmful effects, whether the cessation related information where it is available, you can try quit line number, cessation clinic. So to respond to your question, yes, it has impacted. But again, it matters like the timing of the survey and when the major policies is basically implemented. I hope
sir, like
that
the
answers your question.
significant policies are like the pictorial health warnings and
Exactly.
then quit line helpline numbers, and even there were the strong pictorial health warnings. So what was the size of the pictorial health warnings? 85 up to 85% beyond that were increased. So
Yes.
periodically, what was the impact among the target population?
Yeah. So impact in terms of, I think, see, currently there is one like intern we hosted from UK. So he's exactly working on this topic in terms of impact of pictorial health warning over time. So how the pictorial health warning, the messages, like for example, as we can, like one of some of the key summaries I can recall from the draft paper we already have reviewed is basically
rotatory messages also like those things.
Exactly. So even though the pictorial health warning picture is there, but the industry is making sure that they are diluted in such a way that color combination is used in such a way that it does not convey the same message. Some of the textual warning is basically not visible or it's not proportionate.
Font size and all they're manipulating at the
Exactly.
background.
And again, as you know, that there is a kind of a strong recommendation that pictorial health warning and the images should be routinely changed. So same pictorial warning does not convey, like at initial period where that infected lung. So that infected lung, most of the people, they were getting a message of it is a waterfall. Nobody is getting that message as a kind of it is infected lung. And the color combination is in such a way that it's further minimize the impact of that images. So those are the things. And again, the increase 85%. So that those kind of surveys, I think now.
So again, tobacco-free school initiatives and all, like. So what was the impact on the initiators of the tobacco?
I think we have lost contact with Dr. Mangesh.
Yeah, sir.
Dr. Mangesh, are you with us? I think there must be a net issue. In any case, we need to close.
Thank you.
So we just have 2 minutes with us. So I'll request Mr. Arun Verma to just propose a formal vote of thanks. But before that, I think there is one question of Dr. Vanna. Is it possible can do panel data analysis using ITC data? Dr. Mangesh is not here, so he won't be able to answer. But if Dr. PC Gupta is with us, he can answer that. Dr. Gupta, can you answer that? I think he has also gone. Doesn't matter. So we'll just propose a vote of thanks before we close.
So sorry to interrupt. Dr. Rakesh Gupta sir had his hand raised some time back.
Okay. Dr. Rakesh, do you have any comments to make?
No, I don't have a comment actually, but this is a very complex, exhaustive study.
Yeah.
I was just thinking that this is done in the limited geography of the country. So what will be the stakes for its replicability in the rest of the country? Is there a plan to do so? And if this is done by other stakeholders, what will be the cost of such a study?
Actually,
some of the issues which I had.
Actually, we have lost contact with Dr. Mangesh and Dr. Gupta, but we can put this question to them directly through mail, and so, because I won't be able to answer that.
I know.
Yeah.
I can't. So
yes,
asked in a very honest manner. Yeah.
So, Mr. Verma will propose a vote.
Thank you, Dr. Rakesh. Once again, good evening to one and all. It is my proposed privilege to propose a vote of thanks on behalf of CIPHER as well as ECHO India. Our special thanks we are extremely grateful to Dr. Saurabh, as CEO and Executive Director, AIIMS Deoghar, who has been very kind to accept our request to be chief guest of today's webinar. Our thanks to Dr. Mangesh Suryakant Pednekar, who has made a very exhaustive and a very wonderful presentation. Of course, a very complex one. And I'm sure it will go a long way in adding knowledge to people who have participated, who are our eminent participants. My special thanks to Dr. Rakesh Gupta from Cancer Society, Jaipur, who is always very kind to be part of all our webinars and who has been advising us on all the issues as and when required. My special thanks as well to Dr. PC Gupta, who has always been joining our webinars and who has been always be part of all the information we need on this. My special thanks to Miss Susan, and Dr. Aruna, Dr. Shipra,
Mr. Abdesh.
Mr. Abdesh, and all our eminent participants. And my special thanks to Dr. Rakesh Gupta, our President Cypher, and as well Dr. Sanchika Gupta, Manager Projects of the ECHO India, who was the host for today's webinar. Thank you so much, one and all. Once again, have a great day.
Thank you all. Thank you all.
Thank you so much, sir. Just I need 1 more minute to have some announcements about the next session. The next session is on 5th of July, 2023, that is Wednesday, 4 p.m. The topic is Tobacco Monitor app on mobile-based intervention for monitoring non-compliance. Please do join us on the 5th of July, and we are taking a break for next 3 weeks. And we will see you again. Your feedback link will be shared on your email. Please check your email for filling the feedback form. Your feedbacks will be highly solicited and will help us in improving the quality of the sessions in the future. Thank you so much for joining us today. We will see you again on 5th of July. Thank you.
Okay.
Namaste.
Thank you all. Thank you all. Thank you, Dr. Saurabh. Thank you.
Thank you so much. Thank you, sir.
Thank you all.
Thank you.